Am I audible, sir? Okay. So, yeah, very good morning to everyone present here. Today I'll be presenting my work on a comparative study to determine the outcome of patients undergoing arthroscopic ACL reconstruction using hamstring grafts with and without supplementary tibial fixation using trans-osseous sutures. So, when I had come across this X-ray for the first time, I was surprised and I had a lot of questions. So, we shall proceed ahead to see what was the final outcome of this patient. So, as we all know, the tibial fixation being the weakest link of the initial construct, and adequate initial fixation is thus required on the tibial side. So, there are various methods of supplementary tibial fixation already available, but these methods do have their own set of limitations, such as they involve placement of additional hardware and they come at an increased cost. Thus, we aim to study a hardware-free and a cost-effective method of supplementary tibial fixation using trans-osseous sutures. So, this study was conducted in my institute, SS Medical College, Riva, and over a period of 2 years, 50 patients were selected and they were divided into two groups. Group A consisted of 25 patients operated with supplementary tibial fixation, while Group B consisted of 25 patients without supplementary tibial fixation. All the patients who had a complete isolated ACL injury between 18 to 60 years of age and with or without any meniscal injury were included in the study. The surgical technique was essentially a standard ACL reconstruction using quadruple hamstring graft. The femoral fixation was done using endobutton loop and the tibial fixation was done using a titanium interference screw. The trans-osseous suture fixation, which we have done, is essentially a modification of the technique given by Eisen et al. And Pask et al., whereby the sutures that are used to handle and tension the graft are used for secondary fixation. And this transverse trans-osseous tunnel is made in tibia 1 centimeter below the existing tibial tunnel using a 3.2 mm non-cannulated drill bit from medial to lateral. The bead pin with the suture loop was passed from medial to lateral. So half of the free sutures lying on the medial side were passed to the lateral side through the suture loop of the bead pin, and then they were retrieved back to the medial side anterior to the bone, and then they were tied over the medial side over a bicortical bony bridge. So this basically served as a supplementary fixation for the proximal tibia. So in the post-operative period, all the patients were followed aggressive physiotherapy protocol, and the patients were regularly followed up to 1 year. At the end of 1 year, functional outcome was calculated using the Lysholm knee scoring scale. So here we can see that the demographic parameters of both the groups are comparable. Also, the pre-operative clinical variables are comparable between both the groups. At the end of 1 year, when the functional outcome was calculated, we see that the Group A had a mean Lysholm score of 93.36, while Group B had a mean Lysholm score of 87.32 with a p-value of 0.073. Thus, the findings were not statistically significant. 16 and 15 patients from Group A and B had an excellent functional outcome, while 2 patients from Group B had a poor functional outcome. So on comparing the clinical parameters of the patients after 1 year and the radiological features after 1 year, the difference between both the groups was not statistically significant. Comparing the entry side morbidity of the trans-osseous suture fixation, 5 patients did have a bump of knot underneath the skin, and 2 patients had an hypertrophic scar after supplementary tibial fixation. So coming back to our first case, which I had seen initially, the picture A shows the immediate post-op X-ray of the patient whereby the screw had penetrated intra-articularly. So we had to revise the screw, and at 1 month follow-up, the screw had backed out, and at the 6 months, the screw had completely loosened up and was lying subcutaneously. So we had to remove the screw. Yet this patient had an excellent functional outcome after screw removal at the end of 1 year with a Lysholm score of 95, and this patient had undergone supplementary fixation. So this is another case who is a 50-year-old male where supplementary fixation was not done, yet the patient had persistent instability even after 2 months with a Lysholm score of 54, and thus the patient had to be reoperated with revision ACL using BTB graft. So these are the various other studies who support supplementary fixation, and they advocated it to be done in patients with poor bone quality. So in the end, I would just like to conclude by saying that there is no significant difference in the clinical and functional outcome of patients Also, there is no significant entry-side morbidity and no complications associated with accessory trans-osseous suture fixation. It is a hardware-free and a cost-effective method. Thus, supplementary tibial fixation using trans-osseous sutures can be routinely performed in all the patients, and especially should be performed in patients with osteoporotic bones, as it will serve as a backup fixation. Thank you.
Thank you. Thank you, Dr. Vora. Any question for Dr. Vora? No. Okay. Then you have a seat. We'll finish up with all the presentation and then we'll give certificates.
Thank you.
Okay. Second, I would like to invite Tejaswini Milind Patankar. Dr. Tejaswini? She's not there. Okay. Dr. Kevin Jain? He's also not there. Dr. Hitesh Kumar? Yeah. Fifth presentation, Dr. Hitesh Kumar.
Good morning, everyone. My topic is clinico-radiological correlation of spinopelvic parameter in total hip replacement. First, it is very important to understand the spinopelvic parameter. What is sacral slope? Sacral slope is the angle between the line passing through the sacral end plate and the horizontal reference line. Pelvic incidence. Pelvic incidence is the angle between the line perpendicular to the sacral end plate and the line connecting midpoint of sacral end plate to the midpoint of bilateral femoral head. Pelvic tilt. Pelvic tilt is the angle between the line connecting the midpoint of sacral end plate to the midpoint of bilateral femoral head to the vertical reference line. It is important to understand spinopelvic mechanism. When the person moves from standing to sitting position, what happens is pelvic tilt posteriorly, which lead to the decrease in sacral slope and hence resulting in the increase in functional acetabular eversion. This increase in functional acetabular eversion ensure that the proximal part of femur is accommodated during flexion. Whereas in stiff sagittal imbalance or fused spine, there is less pelvic tilt, which is compensated by increasing femoroacetabular flexion. This increases the risk of impingement and posterior dislocation after total hip replacement. Dislocation after primary total hip replacement account to about 0.3 to 3%. There is increased risk of instability in patient of spinal deformity and sagittal imbalance. Recurrent instability and dislocation remains the frequent cause of revision total hip replacement. Following are my aims to study the correlation of spinopelvic parameter in total hip replacement patient and the clinical outcome in terms of dislocation, impingement, edge loading, and to compare the spinopelvic orientation during different body posture and to study the type of spinopelvic relation. Study comprises of 76 patients who was classified among 4 groups, 1A, 1B, 2A and 2B. 1A being patient having normal alignment, normal mobility, 1A being patient having normal alignment but stiff spine. Here stiff spine is defined as a change in sacral slope from standing to sitting position is less than 10 degree. Whereas 2A being patient having spinal deformity or imbalanced spine, which is defined as the difference between pelvic incidence and lumbar lordosis is more than 10 degree. Whereas 2B being patient having both imbalanced spine as well as stiff spine. In my study, I took pre-operatively and post-operatively standing and sitting lateral radiograph of patient and compare following parameter. When a patient in which the change in sacral slope from standing to sitting position is more than 10 degree, whereas difference between pelvic incidence and lumbar lordosis is less than 10 degree. 1B being patient having stiff spine, that is change in sacral slope from standing to sitting position is less than 10 degree. 2A being patient having flat back deformity or imbalanced spine, where the difference between pelvic incidence and lumbar lordosis is more than 10 degree. 2B being patient having both imbalanced spine along with the spinal deformity. This is post-op X-ray of the patient belonging to group 1A. Here we can see that there is no much change in the parameter post-operatively as compared to pre-operatively. So here the result that the parameter compared pre-operatively and post-operatively didn't show much change. Whereas the patient belonging to group 1A has a tremendous improvement in the Harris score, whereas patient belonging to group 1B, 2A and 2B had comparatively less improvement in the Harris score as compared to patient having belonged to group 1A. So correlation analysis revealed strong association between the clinical outcome in terms of Harris score and the group patient belonged to. Patients belonging to group more than 1A were found to be significantly different in terms of sagittal balance, sacral slope, pelvic tilt, pelvic incidence, and lumbar lordosis. Functional outcome can be improved by adding more acetabulum antiversion in the patient having stiff or imbalanced spine. So there is high risk of instability and dislocation in patient with sagittal imbalance and abnormal spinopelvic motion. By understanding the spinopelvic parameter, preoperatively surgical plan can significantly improve the outcome in patient undergoing total hip replacement. Thank you.
Thank you, Dr. Hitesh. Any question for Dr. Hitesh? Excellent paper, Dr. Hitesh. I have a question. So you have compared it after 6 months after the surgery. Is there any 3 months, 6 months? Why is the duration is 6 months only?
Sir, actually, we need more longer duration of follow-up to check for the impingement or dislocation. But because the study duration is 18 months, so that's why I took 6 months.
So you might plan
Yeah,
to do it
I
after
am doing
1 year.
long-term study, sir, in this
Okay.
to check for dislocation and further impingement or any.
Okay. Thank you, Dr. Hitesh. Okay. Dr. Rahul?
So we call next presentation, sir. Please call next presenter, sir.
Dr. Kevin Jain? Dr. Tejaswini Milind Patankar?
Which session, sir?
Yes, please. Dr. Darshil Shah.
Which one, sir? You're loading, sir?
Yeah, I'm loaded.
When, sir? Morning. Sir.
ठीक है, you can present that problem. Yeah. Okay. Very good morning, respected chairpersons and all my respected colleagues and seniors. So I'm presenting a paper on the functional outcome of hinged knee megaprosthesis and advanced juxta-articular giant cell tumors of the knee. So as we know, giant cell tumors are common benign tumors of the bone, and when it comes to knee, the distal femur is more common than the proximal tibia. These tumors have high incidence of recurrence and also have some amount of metastatic potential. So when we talk about the staging and grading, the Anaking staging divides benign tumors into latent, active, and aggressive forms, whereas the Campanashi grading system divides it into 3 grades, grade 1, 2, and 3, and the grade 3 being the extra-osseous or extra-compartmental spread. There are various management modalities for this, but the most important predictive factor for recurrence is the complete removal of tumor tissues. So current paper is a discussion on 4 cases of advanced juxta-articular tumors around the knee, where we have some common factors that they are all tumors around the knee with a mean age of 34 years. They all presented to us with recurrence or in a late stage of stage 3 with Campanashi grade 3. And so we had decided to go ahead with wide excision and en bloc resection for these patients. And we had, in all these cases, we had done a preoperative biopsy, which came out to be positive for giant cell tumor, and we had done a preoperative CT-guided angioembolization. And we had managed this with a hinged knee megaprosthesis. However, the uncommon factor was that in all these 4 patients, they were managed differently before presenting to us. So this is the first case. This is a 30-year-old male who presented to us with left proximal tibia swelling of duration of 6 months. And here we can see an eccentric expansile lesion of the proximal tibia encasing the fibula, and this is the clinical picture of the same. The patient actually had a past history of left knee pain and swelling 1 year back when he was diagnosed outside as an aneurysmal bone cyst, for which 1% polydocanol injection was given intralesional. However, the patient came to us with an aggressive picture 6 months later, and this was the MRI pictures on presentation. We got a biopsy done, which came out to be positive for giant cell tumor. We went ahead with a wide resection and megaprosthesis for this patient. As you can see, the biopsy scar has been included in the incision, and en bloc excision was done with a 5 centimeter of safe margin. This is the megaprosthesis and is the trial implant in situ. And this is the post-op X-ray for the patient. The second case is a 38-year-old female who presented to us with left distal femur pathological fracture following a history of trivial trauma. The patient actually had a history of interlesional curettage being done 1 year back, and this is the 1 month post-op X-ray where we can appreciate the bone graft in situ. However, this is the 7 month post-op X-ray where we can see resorption of almost entire bone graft. And so since the patient came to us at a late stage with a pathological fracture, we again decided to go ahead with wide dissection with a megaprosthesis. So this is the tibial component, the femoral component, the poly in situ, and the lock at the hinge. And this is the post-op X-ray for the same. This is another case. This 34-year-old male who presented to us with a flexion deformity of 25 degrees with a right knee swelling with history of previous surgery being done. So this was the X-ray on presentation. So the patient actually had undergone intralesional curettage with iliac crest bone grafting, with fibula strut grafting, along with that a plating 1 year back for a grade 2 Campanashi giant cell tumor. However, the patient presented to us with recurrence, and we again had removed the tumor en bloc with safe margins along with the plate. And this was the post-op X-ray for the same. This is an interesting case. This is a 30-year-old female who presented to us 7 months post-op, 7 months history of pain and swelling with of the right knee, and this is the clinical X-ray of the same, showing an eccentric expansile lesion of the right proximal tibia region. However, we had done a biopsy for this patient which came out to be positive for giant cell tumor, and we had given subcutaneous injections of 60 milligram denosumab. 4 doses were given over a period of 1 month, and this is the clinical picture post 2 months of denosumab, where we can see a drastic reduction in the clinical size of the tumor. And this is the X-ray post denosumab, where we can see that the cortex appears more sclerotic. Plus, there is a clinical reduction of the tumor size. Post denosumab, we had again gone ahead with the same management with a wide excision along with a tumor prosthesis. So this is the gait video of 3 of our 4 patients at 2 weeks, 12 weeks, and 5 months post-op interval. So basically the take-home message here is hinge knee megaprosthesis has a very excellent short-term functional outcome in advanced juxta-articular giant cell tumors around the knee with a mean musculoskeletal tumor score of 24 out of 30 at 3 months post-op period. Important is the role of biopsy, which should never be avoided before any surgery or any en bloc excision of giant cell tumors. Another important part is the role of denosumab, which decreases the preoperative morbidity and intraoperative morbidity for the patient. Another important factor is the role of CT guided angioembolization, which decreases the intraoperative blood loss and the intraoperative need for blood transfusion. Thank you.
Thank you, Dr. Kishan. Any question for Dr. Kishan? Okay, please take a seat.
Thank you.
Dr. Darshil Shah.
Yeah. Good morning, everyone. So today I'll be talking about a study that we've conducted on short-term complications of a safety-driven Latarjet procedure in a series of 150 patients. So the aim of our study was to basically describe the safety steps, the 11 safety steps that I'll talk about ahead, that need to be followed in order to reduce the complications in the procedure. So we did a 3-month follow-up and we recorded all the intraoperative and post-operative complications resulting from the Latarjet procedure. So we had a sample size of 150. It was a retrospective study. Inclusion criteria was all the patients with anterior shoulder instability, irrespective of the glenoid bone loss, irrespective of the Hill-Sachs lesion, and who at least had a minimum follow-up of 3 months. Exclusion criteria was any patient with a repaired rotator cuff tear or a massive rotator cuff tear were excluded from the study. The Latarjet procedure was conducted in a beach chair position using the standard deltopectoral approach. General anesthesia plus interscalene block was used. It was the classic Latarjet technique and not the congruent arc. We used two 4.5 malleolar screws instead of cannulated screws that is usually used, and all the 150 patients that were operated upon were operated by a single surgeon. So sorry for this slide being too crowded, but basically these are the 11 steps that we suggest are to be followed in every case meticulously to reduce the number of complications that may occur following the procedure. Just to highlight, especially we focus on the fact that at least we should aim to harvest at least 2.5 centimeters of the coracoid graft in order to have space for two screws to be put in and to prevent intraoperative graft fracture. Furthermore, certain studies suggest that we visualize or release the musculocutaneous nerve in order to reduce the traction on the nerve which may occur during the procedure, but we found but other studies show that we should avoid this, and in our study, in our steps, we avoided neuralizing the musculocutaneous nerve. We suggest avoiding neuralizing the musculocutaneous nerve. Furthermore, because of the scapular anteversion, we need to make sure that the orientation of the screws is quite accurate. So because of the scapular anteversion, the screw should be directed anteromedially to posterolaterally. So basically the screws have to be parallel to the glenoid articular surface to prevent any complications of screw divergence and irritation to the supraspinous nerve. And lastly, we should use a two-finger technique to tighten the screw, because over enthusiastic tightening of the screw may lead to intraoperative graft fractures. So these are a few images showing the first one on the left showing that a 2.5 centimeter coracoid graft is aimed to be harvested at every step. The image in the center is showing the retractor placement. So lot of studies have said that this step should be conducted in the shortest time possible, that is glenoid exposure and graft implantation, because due to the placement of retractors there can be a lot of traction on the surrounding nerves, which can lead to some amount of neuropraxia following the procedure. And the image on the right is showing the two-finger tightening technique of the graft. So we never immobilized the patient. The patient was put in a sling for 2 to 3 weeks. He was advised to self-rehabilitate after post-operative day 2, and we followed up the patients at 2, 4, 6 weeks and 3 months, and at every interval we took an anterior-posterior view and a Bernogio view. So basically our outcomes were, we measured the outcomes in 3 major steps. Basically we divided the complications into 3 types. Type 1 being any complication that didn't change the line of treatment. Type 2 being any a complication which resulted in prolongation of rehabilitation or some sort of medical line of management. And type 3 complication was any complication which led to revision surgery or which affected the outcome of the final outcome of the patient. So the neurological examination in our study was conducted by measuring the power of elbow flexion, shoulder abduction, external rotation, and we also measured the distal neurology. So this took care of the musculocutaneous, axillary, and infraspinatus muscle evaluation. Also, we evaluated the range of motion, that is elevation, external rotation in adduction, and internal rotation. This was measured using a goniometer and also included the non-operative site. So finally, 160 patients were included in the study. However, 10 were lost to follow-up. So 150 patients was the final number, out of which 140 were men, and 30% of these patients were left-sided. Out of the 150 cases, there were 10 revision cases, and these are as you can see, the number of instability patients with the number of instability episodes less than 10 were the maximum. So we had 12 short-term complications in 9 patients, out of which neurological complications was observed in 3 patients, 1 in each of the nerve group. All of these spontaneously recovered at 6 months to 1 year interval. We also had a graft fracture, intraoperative graft fracture in 1 patient, which was then addressed using smaller screws. Just to segregate the complications that we faced, we had 2 type 1 complications, which was hematoma in a patient, which resolved at the end of 1 month. 5 patients had type 2 complications, out of which, like I mentioned before, 3 were nerve paresis, which resolved by 6 months to 1 year. We had a wound dehiscence, which was addressed using local anesthesia, sutured, resuturing done under local anesthesia. And more importantly, 2 patients had type 3 complications. Like I mentioned, one had an intraoperative graft fracture, which led to and shoulder stiffness, and one patient had shoulder stiffness. So this is the deficit that the patients had. This is just further breaking it down. So the strengths of a study is that we had a large sample size. It was a consecutive series of patients, and all of these patients were operated by a single surgeon. The limitations is because it was operated by a single surgeon, there's lack of external validity, because we don't know if the same results can be obtained if another surgeon is following these steps. We only had a 3-month follow-up, so we aim to increase that, and once we obtain a longer follow-up of patients, we aim to republish our study. And we had only 10 revision cases out of the 150. So we don't know, in case we had more revision cases, probably the number of complications may have increased. But studies have shown that the complication rate in revision cases and primary cases have been the same, the previous studies. So take-home messages are that all these 11 safety-driven steps should be followed. Aim to at least, we emphasize a lot on the fact that we have to achieve at least 25 mm of the coracoid graft. Walsh's 2-finger technique is used to tighten the screws. And like I mentioned previously, the glenoid exposure graft fixation should be completed in the shortest time possible. Most common nerve involved is the musculocutaneous nerve. And even though all these safety-driven steps may be followed, there may be still some amount of neuropraxia that may be observed in some patients. So we should aim to counsel our patients thoroughly to the possibility of some amount of nerve paralysis, which usually recovers though by the end of 6 months to 1 year. Thank you.
Thank you, Dr. Darshil. Any question for Dr. Darshil?
So 2 fingers are, so when we tighten the screws, usually we grip it with the entire hand, and we are aggressive with the tightening. So here we tighten it only 2 fingers, so that in order to avoid, yes, 2 fingers basically. So yeah, not the full hand, because you may reduce the torque basically.
Okay, thank you.
All right, thank you, sir.
Dr. Tejaswini.
So good morning, everyone. Today I'll be presenting on the effectiveness of volar corrective osteotomy and bone grafting for extra-articular distal and radius fracture malunion. So I have no conflicts of interest. So Gartland had described that after a conservative treatment, there is 60% of them assume a pre-reduction alignment. And incidence of malunion after a conservative management is 23.6%, and incidence of malunion after operative fixation is 10.6%. So a symptomatic extra-articular malunion of distal radius may present with pain, loss of motion, cosmetic deformity, decreased grip strength. So pain can be in the radiocarpal region or midcarpal or distal radial ulnar joint. So the radial inclination can significantly lead to cosmetic deformity, and tilt is a very important factor determining the symptoms. So the aim of our study was the correlation of radiological parameters on patient-rated wrist evaluation, the effectiveness of the osteotomy in correcting the radiological parameters, the clinical and functional improvement following the osteotomy, and assessing the influence of degree of radiological parameters in correction to the risk scores. So materials and methods, this was a retrospective study which was conducted from 2010 to 20. A patient list was generated in this computerized hospital information processing service. CT images were used to exclude the fractures that are intra-articular patterns or extension. So radiographs, that was a PA and a lateral view, were included. The initial fracture patterns were classified according to AO, Frickman, and Fernandez type 1 fracture classification for the distal and radius fractures. So the inclusion and exclusion criteria were, that is, the inclusion criteria were patients with from 18 to 50 years, and no other previous injuries or fractures, no wrist arthritis, extra-articular distal and radius fractures, no other associated upper limb fractures, and minimum follow-up of at least 24 months. The exclusion being intra-articular fractures, they had previous surgeries, CRPS, osteoporosis, ulnar fractures, carpal fracture, or osteomyelitis. So functional evaluation was done pre-operatively and post-operatively using the visual analog scale, the patient-rated wrist evaluation questionnaire, the Mayo risk score, the quick dash questionnaire, and the functional analysis was done using the range of motion and grip strength. So the radiological evaluation was done using the radial inclination, the tilt, ulnar variance, the scapholunate, lunocapitate, and the radiolunate angles. So the surgical technique, which was a volar open wedge extra-articular osteotomy using a rigid plate fixation with a tricortical iliacrest bone graft. A modified Henry's approach was used. It was a metaphyseal osteotomy. We used a volar locking plate fixed over the distal fragment. The correction was performed under the fluoroscopy. The tricortical graft was inserted, and post-op these patients was casted for a duration of 6 weeks, following which a 3 weeks physiotherapy was undertaken. So the statistical analysis was that the mean, SD, mean, and range were used to describe the demographics and the outcomes. So differences in pre and post-operative was done using the Spearman's Rho coefficient, and the correlative between the scores was done using the Wilcoxon's paired t-test. So analysis were performed using the SPSS software. So the observation was that we had 90 patients who had distal end fracture malunions, which underwent various surgical procedures, out of which 21 qualified the inclusion criteria, and only 12 responded to our study. So there were at least male to female was 5:1, and all the patients were right hand dominant, with the injuries noted to be right to left as 2:1, and the mode of injury was noted to be RTA in 4, and 8 had a history of fall. There was one patient who had an open injury. So depending upon the fracture type, as per the AO classification, AO to A2 was the maximum that was seen in about 80% or 66 to 70% of the patient, and A3 in 30 to 33.36% of the patient. And frequent, we noted 58% type 1 and type 2 in 42%. So the observation that initial treatment was conservative in 8%, 8 patients, and K-wire and external fixator for 4. There were 2 smokers with an age in our study was 40 plus or minus 2. Duration before the osteotomy was 3 to 6 months with a mean follow-up of 85.58 months. All united at 6 weeks, and no infections or wound problems were noted. So we noted a significant post-operative value, that is between the mean post and pre-op values of dorsiflexion, palmar flexion, and ulnar deviation. So these were the mean pre-op and post-op values as calculated by Spearman Rho coefficients. That is, we got a pre-op and post-op significant values for grip strength, active pronation, supination, radial inclination, tilt, ulnar variance, scapholunate angle, and also significant changes in the functional parameters such as VAS, patient-related wrist evaluation, Mayo Risk score, quick dash questionnaire. So we achieved the following corrections as previously mentioned. So the functional score change was also significantly noted in all these patients. So according to the radiological corrections versus the functional score change, that is the radial inclination to that of the VAS, PR, the patient-rated wrist evaluation, and Mayo Risk score, we found a significant correlation for all, and also for the scapholunate angle as compared to the lunocapitate and the radiolunate angle. So the radial inclination was influencing the VAS, as which was not noted in the ulnar variance and tilt change. So results that clinical and statistically significant improvement was noted in radial correctional and functional score change, that is dorsiflexion, ulnar deviation, pronation, supination, grip strength, and radial inclination, tilt, ulnar variation, and scapholunate angle measurements on radiological assessment. So discussion being that functional outcome, we found significant improvement in VAS, the patient-rated wrist evaluation and Mayo Risk score, and activate-rated outcome as dorsi, palmar flexion, ulnar deviation, radial deviation to the VAS, Mayo Risk score, and PRWE. So the discussion is that significant correlation is between the radial inclination and ulnar variance to VAS, Mayo Risk score, and the patient-rated wrist evaluation. With tilt difference also were noted to the VAS and the PRWE score was in our study. Similar results were noted by Batra and Gupta in their study, and the radial length and volar tilt as they had determined as the most important predictors for functional recovery at 1 year. So scaffold unit, lunocapitate, and radial unit angles have a significant correlation with the Mayo risk score and the patient-related risk evaluation. So it was also stated that carpal instability adaptive have also been noted and correlate with the radial unit and ulnar variation and dorsal angulation, which was described by Rubinovich. So this is our patient one who came to us with a significant extra-articular distal and radius fracture, which we originally did it with the external fixator, following which we did an iliac crest bone grafting with a plate fixation. This was a second patient whose post-op images are displayed on the left side, right side, and the left side you can see is the pre-op images along with the post-op images of the patient. This is patient 3, post-op images. And so take-home message is extra-articular distal and radius malunion have a significant functional morbidity, and volar open wedge osteotomy could restore the radiological parameters, clinical and statistical significant improvement in patient-rated wrist evaluations. Thank you.
Thank you, Dr. Tejaswini. Any question for Dr. Tejaswini? No? Then please collect your certificate from our chairpersons. Dr. Kevin Jain is here. He has not come. Dr. Abhi Vora. Dr. Darshil Shah.
Dr. Rahul Kesan.
Dr. Hitesh. Yes. Dr. Hitesh. Okay, one common photograph of conveners, presenters, and chairpersons. All the presenters, please come on stage.